nasal cavity, it's two-way opening. Anterior there is opening and posteriorly also. So if the blood goes into your nasopharynx, then into your larynx, then into your trachea, then into your lung, what will happen? You will have aspiration, right? And this can lead to death. তাই তো হেমারেজের জন্য না ডেথ যতক্ষণ না হলো অ্যাসপিরেশনের জন্য তার আগে ডেথ হতে পারে, রাইট? সো দ্যাটস ওয়াই nasal hemorrhage is studied separately. Okay. Other complications, nasolacrimal duct damage. Why? Nasolacrimal duct, where does it open? Which meatus? Which meatus? Which meatus? This is the fourth class. I am telling the same thing. Nasolacrimal duct opens in inferior meatus, right? So nasolacrimal duct that is hidden behind the lacrimal bone and the ascending process of the maxilla, right? You can damage that structure. What will happen if you damage the nasolacrimal duct? Patient will have epiphora. Okay. Extraocular muscles injury you can have if you go directly to the orbit. Intraorbital hemorrhage. If there is intraorbital hemorrhage, there is orbital, there is a large hematoma and it's causing pressure. What will happen? It can damage the optic nerve, right? Patient will be blind. So optic nerve damage. So intracranial you can also injure big vessels like internal carotid artery branches, anterior cerebral artery or middle cerebral artery you can damage, right? So you will have stroke and obviously CSF leak, right? If you damage the skull base during the surgery. So coming into this question, what is this? This patient is having severe bleeding from the nose, right? So what is your diagnosis? Epistaxis? Anterior or posterior? Anterior or posterior? Anterior, right? How will you manage this patient? A patient coming to you with bleeding anywhere in your body. First step is you have to resuscitate the patient, right? How will you resuscitate? ABCDE criteria, ATLS guideline, right? So you will look for if there is any airway problem, breathing problem, circulation problem, all these things. You put a channel, put a catheter if there is severe bleeding, right? Okay. And next you will try to stop the bleeding, right? So you can be very lucky to stop it with minimal intervention. Sometimes you are very unlucky that it is not stopping. Then you have to do special things, right? And another thing, if the patient is having comorbidities like very high blood pressure, severely malignant hypertensive, okay, then we have to manage the blood pressure as well side by side, right? So now coming this question number 3, 3 specific causes or precipitants of this complaint. That means name 3 causes of epistaxis, right? Most common causes of epistaxis. 1, speak out, speak out. Trauma. Next, hypertension. Next, there are many thousands, hundreds of causes. More common causes, hypertension, trauma, and if there is any tumor or foreign body, bleeding tumor, right? Or sometimes there is bleeding diathesis. Sometimes patient is on blood thinners, anticoagulants and all. And there is as well as increase in blood pressure. So patient will bleed easily, right? And now coming into this question again, every day I am asking, name the artery supplying the nasal septum. This question will be asked in the exam 100%. Okay, what is little area, what is Woodruff plexus, what are the blood supply. So everybody can name the blood vessels, the supply. I hope so. We will see in the exam. So this is the answer. This is the question. What is your diagnosis? You can see a polyp there, right? A and B. This is A, this is B. This is anatomy. Anatomy পড়া হলো হয়েছে তো এতবার করে পড়া হলো. Next, I think the second next class, I will ask everybody questions. It will be interactive. Okay? Everybody must answer. Otherwise, rhinology will not get finished. I have to come back again. Anyway, this is another question. These questions will be asked. আমি কোশ্চেনও বলে দিচ্ছি. Okay, what is this diagnosis? You can see there is a swelling just along the nasal septum, right? This is your nasal septum. There is a swelling, boggy swelling, both sided, right? What it can be? কি হতে পারে? There is a collection, something is there. It can be blood, it can be abscess, right? So suppose I am giving you the history. The patient have a trauma, and patient is coming to you 2 days after trauma with nasal obstruction and severe pain, and with this clinical picture. তাহলে কি হবে? What is the diagnosis? No fever, nothing. So hematoma, right? So septal hematoma. It's an emergency. Just মনে রাখার জন্য ছবিটা দিয়েছি, okay? If you see this case, it's an emergency. Why? This hematoma, if there is any hematoma, it will what? Destroy the cartilage of the septal cartilage. If a septal cartilage টা যদি destroy হয়ে যায়, what will happen? If the cartilage is got necrosed, what will happen? Saddle nose. That means it will depress overall. The structure itself will collapse. Right? Okay. So how will you manage this patient? We have to drain it. I told it is an emergency. You have to drain it as soon as possible, right? And what are the complications? That's saddle nose, right? And if there is build-up of abscess, the hematoma got infected, ultimately it will be abscess, then it's more emergency because it's an infective etiology, right? You know, this area of face is known as dangerous area of face. It has connections all together into your brain, right? Through your blood vessels, blood channels. So you will have all the complications possible. Orbital cellulitis, meningitis, this and that, right? All the infective complications you can have, okay? Abscess, sepsis, meningitis, ultimately the cartilage is destroyed, there will be perforation, right? Orbital cellulitis, cavernous sinus thrombosis, saddle nose deformity, all these things. How will you manage it? Early drainage, as soon as possible. So CSF rhinorrhea, again, last day I have told many things. Mostly in the cribriform and roof of the ethmoid, there is a fracture. This is the most common area. This comes in the MCQ. And sometimes, without any cause, it happens, okay? If it is traumatic, most of the cases, it got healed, right? If does not get healed, then we have to do some intervention, right? So 16% of the cases are iatrogenic. That means during surgery, we damage the skull base, right? And endoscopic sinus surgery is the most common cause, okay? And non-traumatic, high pressure leaks, very important. Middle-aged, obese female coming to you with watery discharge from the nose unilateral. You will suspect idiopathic cause of CSF rhinorrhea, right? Most common cause is idiopathic intracranial tension is raised, right? Other causes, some tumors like pituitary related tumors and hydrocephalus communicating or obstructing. So normal pressure leaks in 55% cases. The pressure is not increased at all, but there is a leak, right? And other causes are true spontaneous leak, that is in adults, and osteolytic causes, blah, blah, blah. Congenital causes are also there. How will you work up? History is most important. to differentiate between whether it is a allergic rhinitis or a CSF rhinorrhea, right? So you have to ask again and again, unilateral, watery, clear discharge, mostly CSF, okay? And now you will ask the patient to stoop forward and see whether there is any active leak or not. If there is any active leak, you will collect in a filter paper or blotting paper and you will see some things. We call it target sign. Okay, if there is CSF, it's like water. It will not have any circle around or different specific gravity, and this target sign will not appear. Okay, but if it is a discharge because of the allergic rhinitis or other causes, chronic rhinosinusitis, you will get the sign. And you will examine with nasal endoscopy, and you will have other imaging. Okay, this is this halo sign or ring sign or target sign or what. Okay, blood will separate out from the CSF, central blood with clear ring, that is the halo sign. Okay, if you can see many other layers, 4 or 5 layers, mostly it is because of the nasal discharge. Okay, but it's not specific. Okay, sometimes the CSF can be mixed with your nasal secretions. Okay, so what are the investigations to confirm whether it is CSF or something else? You will do this test, beta-2 transferrin. Okay, this is also an MCQ question. It will be asked in your exam. How do you investigate? The best investigation is MRI cysternography. If you are asked in the exam what is the best investigation for CSF rhinorrhea, okay, the answer will be MR cysternography. The alternative is CT cysternography. Okay, but you should do both the investigations. MRI to see whether there is any brain prolapse or not, CT to see whether there is any bony defect or not. Okay, but these are not easily available, so mostly we start with high resolution CT scans, normal CT scans. Okay, you can do radionuclide scintigraphy. It's also very specific, but problem is even if there is no active leak, you have no result. Okay, so false negative results are very common. So look at this picture, you can see this is the skull base area. Okay, so this is your paranasal sinus, right? One cut. This is the maxillary sinus. This is your nasal septum. You can see a little bit deviation is there. You can see there is a spar here. Okay, this one, and this is your inferior turbinate. This is your middle turbinate. Okay, here also. These are your ethmoidal air cells, right? This is your orbit, right? And this is your cribriform area, the skull base, right? Just see, look at this picture. There is this is the brain, frontal lobe of your brain. It's prolapsing. There is a defect, right? It's coming into your nose. Okay, this is your brain matter along with meninges. Okay, so there is a defect, bony defect, and it's prolapsing, and you will have CSF leak here, right? So again this thing, fluorescent dye, we use fluorescent dye as well during the operation to see if the leakage is completely closed or not. Okay, so it's mostly intraoperative finding. So how do you treat CSF leak? Few cases you will do conservative management. Suppose there is a traumatic leak, mostly responds to conservative management. Conservative means with medicines. Okay, no surgery is required. And bed rest, keep your head elevated, avoid nasal blowing, blah blah blah, all these things. Avoid heavy lifting, whatever is causes increased venous pressure in your body. Okay, like heavy weight lifting, blowing of the nose, Valsalva, all these things. If you are doing, the CSF will be leaked more. So you should avoid all these things. You can give diuretics, acetylzolamides, okay, all these things to lower down the CSF pressure. But you can also give lumbar drain. But the definitive management is operation, like surgery. What will you do? You will go through an endoscope, you will leak, close that leak, okay. Now coming into the question, frontal head trauma, clear rhinorrhea. What is the diagnosis? CSF rhinorrhea. What is the imaging modality? First investigation is CT scan, but the best investigation is CT cysternography. MR cysternography, right? See, this is the picture, right? This is your frontal bone, right? From here starts the parietal bone. This is your brain. This is your scalp. This is the covering of your brain, that is the meninges, right? This is your frontal sinus. You can see there is a fracture here, right? There is a fracture here as well, okay? This is the posterior table of your frontal sinus. This is the anterior table of your frontal sinus. So if both the tables are getting fractured, what will happen? CSF will leak. CSF will go to your frontal sinus and it will go to your via your nose, right? So we call it CSF rhinorrhea. What will you do in this case? How will you manage this case? Huh? Ki bollam? Traumatic? Huh? What? Conservative management first, right? With medications, with bed rest, with all these things we will observe. Then even if after all these things it's not get healed, we will go for surgery. Okay. Okay, coming to the question again. What is your concern? What is the biggest concern? If the leak is persisting, what will happen? Patient will have ultimately meningitis, right? A patient will die. What is the test? Definitive test from the fluid? Beta-2 transferrin. And what are the principles of managing the rhinorrhea? It's a big question. Leave it. Coming to this question. This patient has a fight. নাকের মধ্যে দুরুম করে একটা ঘুষি মেরেছে, যেটা কমনলি আমাদের রাজ্যে হয় বা দেশে হয়। তো দেখতে পাচ্ছ there is a deviation, right? External দেখতে পাচ্ছিস সবাই? See, there is a deviation, right? We call it crooked nose deformity, right? Or crook nose deformity, whatever you want to wish to call, American style or British style, doesn't matter. So crook nose deformity, right? So another thing, blood supply of the nose, blood supply of the this thing. What will you advise if you are the casualty officer or the medical officer in the emergency? What will you advise to the patient? See, patient যদি epistaxis থাকে, you will manage that epistaxis, তাই তো? Patient যদি septal hematoma থাকে, you will manage the septal hematoma. How will you manage the septal hematoma? You will do the incision drainage, right? There should not be any hematoma or abscess around your septum. Okay, it will lead to catastrophe. And how will you manage this thing, this deviation, this deformity? Rhinoplasty, septal, you will do some surgery, right? So in a fresh case, mostly closed reduction is enough. But if it is old enough, we have to open it up and do the corrective surgery. We call it rhinoplasty, right? This is another question. See, the first thing, unilateral extend towards choana. There is a polyp. Unilateral extending to the choana. What type of polyp it is? Anterochoanal, right? If it is bilateral and coming anteriorly, it's mostly ethmoidal. So what is the best investigation? CT scan, right? CT scan will give you many important things. Okay. What is this? This patient is coming with neonatal emergency. Okay. Just by birth, patient বাচ্চা একদম 1 মিনিটের বাচ্চা, পেশেন্ট নিঃশ্বাস নিতে পারছে না। What is your diagnosis? This is your choana, right? You can see this choana is blocked. There is a this should be open. Black means air, right? There is no air passage. This air passage is blocked with this something here in the choana. We call it choanal atresia, right? Bilateral choanal atresia is absolute emergency. Patient will not survive in most of the cases, but unilateral usually survives, but we have to correct it as soon as possible, right? Why? Patient এর তো মুখ রয়েছে, বাচ্চার তো মুখ দিয়ে তো নিঃশ্বাস নিতে পারে, পারে না। Neonates and young babies, they are nasal breathers. They cannot breathe through their mouth. So nasal airway have to be patent. Okay. So how will you manage? What are the signs? All these things, this will be asked. Bilateral. See, black is air. So paranasal sinus usually ideally should have air. Black city, both sided. Bilateral. Bilateral polyp. So what is the diagnosis? Huh? Ethmoidal polyp. So it's extensive, right? It's involving almost all the structures. So I have given you few syndromes. I have told yesterday in the last class, sorry, that there are few syndromes where you appreciate these findings. Extensive bilateral nasal polyps. What are the syndromes? Anybody? Nobody can remember. So this is the question that I will ask again. Okay? I am giving you the privilege that I am disclosing all the questions already. You have to get the answers. This is also, you see, something is in the choana. Something is in the choana, right? It's coming through your nose. What it can be? What it can be? These are all real life pictures, right? সত্যিকারের পেশেন্টদের পিকচার. These are having some values. Okay. So these are the questions I will ask. So something nasal mass coming into the choana. Differential diagnosis. Antrochoanal polyp. But it can be many other things, right? Differential diagnosis. Angiofibroma, meningoencephalocele, inverted papilloma, mucocele, paranasal sinus, all these things. Okay. So inverted papilloma is also a thing. Middle-aged male patients mostly coming with malignant, bleeding. The diagnosis is inverted papilloma. This is also a separate pathology. Just remember the name. Okay. This is a differential diagnosis, and cross classification is there. See. This is the thing I discussed in the last class. Okay. The complications of acute rhinosinusitis, the stages. Right? There are 5 stages. বলেছিলাম? Chandler's staging system, I told. Preseptal cellulitis, orbital cellulitis, abscess, cavernous sinus thrombosis, 5 stages. Okay? You have to remember this thing. How will you manage this patient? সব কিছু বলা হয়েছে. Just look at the picture. Patient with there is a swelling around the right eye, and this is the CT scan picture. You can see there is a preseptal abscess. This is another question. What is this? This is your inferior turbinate. Huge. Inferior turbinate is huge. Okay. So this is inferior turbinate hypertrophy. অনেক সময় বাড়ির ছোট বাচ্চাদের দিয়ে মারা খুব কনসার্নড হয়. They see the nasal cavity of their babies and appreciate there is a swelling inside, reddish swelling, right? Mostly it is inferior turbinates. Okay. These are not polyps. They come to us that doctor, there is a polyp inside my baby's nose. It's not. Okay. So inferior turbinate hypertrophy, most common cause is allergy, right? Allergic rhinitis. So there are other causes also. Okay. So rhinitis medicamentosa is one of them. What is this? It's mostly found in xylometazoline or oxymetazoline abusers. Every day otrivin. Okay. Long term use. Those patients become dependent on those xylometazoline or oxymetazoline, right? Those patients, even if there is no anatomical obstruction, patient appreciate there is always an obstruction. We call those conditions as rhinitis medicamentosa, right? Other causes in acute rhinosinusitis, chronic rhinosinusitis, non-allergic sinusitis, congenital causes, neoplasm, compensatory hypertrophy if there is any deviation, all those cases inferior turbinate hypertrophy is there. Look at this picture. What is the abdominality you can see? This is your nasal septum, this is your inferior turbinate, right? you can see lots of crusting there, right? And what is this picture? This is your septum. There is a big perforation, right? This is septal perforation. Okay, and this is inferior terminate ulcer, right? How do you treat inferior terminate hypertrophy? There are many treatments. You can reduce it, you can cut it out, right? So, inferior terminate has specific function. It maintains the nasal airflow in a particular direction. So, inferior terminate jodi bad diye dao, the condition appears is atrophic rhinitis. What is atrophic rhinitis? Everything is atrophied. সব কিছু নাকের মধ্যে শুকিয়ে গেছে. Those patients present with what? Very foul smelling nasal discharge. নিজে কিন্তু গন্ধ পায় না. Okay? Patients নিজে গন্ধ পায় না because the olfactory fibers are also atrophied. But patient এর পাশে যে বসবে সে মারা যাবে রীতিমতো. এত বাজে গন্ধ হয়. ঠিক আছে? Classical, those patients got repeatedly infected with Klebsiella and other polybacteria. Then this patient coming to you with the complaint that my neighbor or my parents, my husband, my wife, my close relatives, they are complaining that I have very foul smelling nasal discharge, right? What is this? A perforation? Septal perforation. Septal perforation হলে কি হবে? পেশেন্ট যখন নিঃশ্বাস ছাড়বে হুইসলিং সাউন্ড আসবে, ভেরি bothersome. পাশে বসে আছে বাঁশির মতো আওয়াজ আসছে. ওকে, so if it is big enough the sound is less, small enough sound is more. Newtonian fluid principle. Okay, so how will you treat this? Another complaint will be there will be crusting because there is raw area and patient will have repeated epistaxis, right? So how will you treat this? Okay, 5 blood tests because there are many causes of this thing. Okay, septal perforation. One of the important causes trauma, another is during surgery, another is granulomatous diseases, very important. Okay, like TB, sarcoidosis, your syphilis, all these things you can have septal perforation. Wagner granulomatosis. So you will do ANCA for Wagner granulomatosis. I told you in the last class. Serum ACE level for angiotensin converting enzyme level raised in a case of sarcoid, right? So the medicine পড়াচ্ছি আর তো কিছু না. So in medicines ACE level are raised. VDRL for syphilis. Okay. So how will you treat? You will try conservative ointment and all. Okay, but ultimately you have to go for a surgery. Surgery is critical, difficult, all these things. It's not in your domain. Septal button also you can apply. This is a button. You just push it. It will close the perforation area. Again, this question again. Infant, you can say 2 years old boy. This finding. So this is a complication of acute rhinosinusitis, right? Again, it will come under the Chandler staging, and if there is any abscess development or something, you will go for urgent surgical management. This is mostly your general surgery you will be taught and your dermatology as well, but it comes under our domain as well. This is a basal cell carcinoma, right? Rodent ulcer as well as it's also called. This is your, I was telling you that lacrimal duct, how does it drain? Lacrimal gland, after that the tear goes to the, this is the lacrimal canaliculus, superior lacrimal canal, inferior lacrimal canal, ultimately to the lacrimal sac, then to the nasolacrimal duct, ultimately drains into the nasal cavity, right? In the inferior meatus. Okay, it has 2 valves, valve of Rosenmuller, valve of Hassner. These are the MCQ questions. Okay, intentionally I have put all these things because any time of your carrier, this will be asked. So anosmia, what is anosmia? Loss of smell. Anosmia, causes of anosmia, you will be asked. Any obstruction, we call it conductive. The air is not reaching the olfactory area. So sinonasal pathology, adhesion, synechia, some sensory neural, post-viral neuritis, trauma, idiopathic, iatrogenic, and central cause Alzheimer's, Coleman's disease syndrome, neoplasm, and epilepsy. Okay, and I told you this upset you have to remember to test the olfaction. Now coming to the question. 55-year-old chef ranna kore, complains of inability to detect the odors. He has no significant past medical history and otherwise fit and well. How will you manage this patient? Management means what? Management means diagnosis plus treatment, right? So how will you manage this patient? How will you diagnose what happened to him? Anosmia, right? You will get a detailed history and detailed examination. Examination starts with endoscopy, nasoendoscopy. You will look at that area, then you will go for a detailed olfaction test. This is a question that can be asked in your exam. And then you will go to the imaging, right? Start with CT scan, go to the MRI brain. How do you treat it? Very important. A question ta MRCS examination e ashe, okay? Very frequently. Suppose কুক তো বাড়িতে তো গ্যাস রয়েছে, গ্যাস লিক করছে, গন্ধ পাচ্ছে না, আগুন লেগে যাবে তো, তাই তো? সো গ্যাস ডিটেক্টর or the fire detector you have to install. You have to tell the patient that install a fire detector. Okay, electric cooker if possible change it. Okay, each and every food item he has to check. You will advise the patient apart from the treatment. You have to check the manufacturing and expiry date. পচে গেছে, গন্ধই পেল না, খাইয়ে দিল তোকে, it will be an emergency. Okay, so personal hygiene, all these things. Okay, and sinonasal tumor, this will be read in detail. Okay, angiofibroma. So let us see. I will give a little bit of introduction. Angiofibroma is a tumor, it's a very rare tumor, mostly occurring in the adolescent male. Okay, that's why it's called juvenile, in juvenile age group. Male patient, একটা 12-14 বছরের বাচ্চা সকালবেলায় ঘুম থেকে উঠলো, একদম পুরো বিছানা ভর্তি, বালিশ ভর্তি রক্ত from nose. It's happening again and again and again. You will suspect we might have this thing, nasopharyngeal angiofibroma. Okay, so it's the symptoms are there is nasal obstruction and recurrent epistaxis, and it has a property of expansion, right? It expands to difficult areas of your nose, paranasal sinus, and ultimately into your brain, and very vascular. As it is very vascular tumor, that's why we read it separately, because during the surgery you might encounter 4 liters, 5 liters of blood loss even. Okay, we have operated one case, 4th time recurrent case. He had to get the transfusion of 6 liters of blood, okay, during the surgery. It bleeds so much. So if it bleeds so much, if we suspect that there is a tumor inside your nose, mostly what we do, we get a biopsy. First we get a biopsy to see whether it is benign or malignant, then we plan accordingly, right? But in this case, even if it is a benign tumor, you will not get a biopsy. If you get a biopsy, you will be in trouble. The bleeding will start, right? Okay, so the surgeries has to be done by very expert surgeons who can able to handle this bleeding, okay, who are able to handle this bleeding. To stop the bleeding, to reduce the bleeding, sometimes we preoperatively embolize the vessel, and sometimes we give radiotherapy as well. Okay, radiotherapy, but it is a benign tumor, right? Radiotherapy mostly for cancers. and the feeding vessel is ascending pharyngeal artery. Okay. Now, this patient, 50-year-old man, you can see this thing, persistent excessive nasal crusting and epistaxis. Okay. Aged patient coming to you, persistent, this thing and epistaxis. Okay. So, atrophic rhinitis is the most common cause. I told you atrophic rhinitis, this crust, these smell so bad. Probably the worst smell in human body. Okay. Smells the worst you can imagine. Mostly atrophic rhinitis, but voisinous granulomatosis also you can see this thing. This is a question again, 47-year-old man referred back to your clinic 2 years after having had a sinonasal surgery. কেউ একজন বিখ্যাত সার্জন এই সার্জারিটা করেছিলেন, ওকে? And he complains of bitterly of nasal congestion, scabbing and dryness. I told you he removed everything. The turbinates are removed, right? Everything is removed and ultimately everything atrophied. So atrophic rhinitis. Nothing to filter out. This patient will come to you. You can detect the diagnosis. You can have the diagnosis from 1 kilometer. Okay, 1 kilometer থেকে গন্ধ আসছে. You will find there is a patient of atrophic rhinitis in your chamber. Also, it starts with empty nose syndrome, ultimately to atrophic rhinitis. Again, this question, 45-year-old man, Middle East, from the Middle East, from Dubai or Saudi or something. Huh? These are real life situations, okay? Kono question bank theke tola questions noy. These are the patients who came to me literally originally. Okay? Middle-aged patient, nasal obstruction, epistaxis, anosmia, foul smelling, green yellow crust, occasional choking episode. Okay? Patient has been operated previously with endoscopic sinus surgery. Concha bullosa, I mean the middle terminate is reduced. I mean it has been cut out, and inferior terminate also. The same thing, atrophic rhinitis. Okay? So, the first diagnosis is atrophic rhinitis, but ultimately we got in this patient a leprosy. Okay? Epistaxis means bleeding from the nose, from the nostril, from the nasal cavity, from the nasopharynx, all these things. Sometimes is life threatening. Okay? Most commonly in aged patient and in young patients. Why the bleeding from the nose is very common? নাক দিয়ে রক্ত পড়ছে ব্যাপারটা বেশি কমন না হঠাৎ করে? Any other organ থেকে এরকম রক্তপাত হয় কি? Because it's a vascular organ and we live in a country with incredible heating and heat and humidity, I mean the dry weather, and vasculature is run just under the mucosa. It's open. Just একটু scratch লাগলে there will be bleeding and very rich anastomosis, and both the internal carotid and external carotid have supply into your nose. The blood supply of nose again অনেকবার বলা হয়েছে. What are the blood supply? This slide আমি বারবার repeat করি because you cannot afford to miss any point here. Again and again and again and again. Woodruff plexus and Kesselbach or little area. This will be asked in your exam. Little area anteriorly. It's a rich vascular network. All the blood vessels, mostly only the posterior ethmoidal vessels does not come into the anastomosis. So this anterior area very prone for bleeding, right? And Woodruff plexus mostly from the sphenopalatine artery and posterior pharyngeal artery. It's located posteriorly. Okay. Okay. So sites of epistaxis. Any site can be a site of epistaxis. Mostly the little cilia, the most common. Above the level of the middle terminate, below the level, posterior part, I mean the Kesselbach, Woodruff plexus. It can be diffuse from the nasopharynx as well. Diffuse bleeding mostly hypertensive, and if there is any vascular, I mean bleeding diastasis. Bloody যদি নিজেকে ক্লট না করতে পারে, it can bleed from anywhere, right? So causes of epistaxis, I will continue from the next class. Epistaxis will be covered elaborately, okay?